A 60-year-old gentleman was referred to us with suspected mass in the head of the pancreas leading to severe cholestatic symptoms. You can see a large hypoechoic irregular mass with calcification in the head of the pancreas, measuring 5 centimeter by almost 2.1 centimeters, including it's impossible to see the major vessels. The tumor is taking away all the energy there, and you can see that the bile duct is occluded with massively dilated CBD. Few peripancreatic hypoechoic nodes were seen. Echogenic bile was also seen, suggestive of a mild episode of cholangitis. Gentle withdrawal of the scope showing dilated, very massively dilated pancreatic duct with a chain of lake appearance when we see advanced chronic pancreatitis. So it's difficult to ascertain whether this patient had calcific chronic pancreatitis and there is a mass within the setting of chronic pancreatitis. We are looking for lymph nodes, and yes, we see small, tiny hypoechoic nodes in the celiac axis region. Now, it's important to magnify the image and see these are round hypoechoic sub-centimeter 7 millimeter node in the celiac axis region with a large tumor in the head of the pancreas, dilated bile duct, dilated pancreatic duct, and careful observation of dilated pancreatic duct would probably also show some mural nodules occasionally. Here not very classical, but there is some question mark which is protruding in the pancreatic duct here in the body of pancreas. So either we dealing with a metachronous lesion within the pancreas, or it's a mucin plug in the dilated pancreatic duct. It's difficult to assess only on the basis of EUS morphology. This is a celiac artery you saw, the splenic vein going into the tail region here, and the lymph nodes in the celiac artery, which are hypoechoic and subcentimeter. Mediastinal evaluation is being done. There is no evidence of nodes in the mediastinum. So then we proceeded first with EUS-guided FNA from the celiac node, because we want to use the same needle for the primary lesion as well. So if the celiac node is positive for metastatic disease, these are the nodes which are tricky to FNA. You have to have a jabbing movement like a staccato action where the needle enters the node, and do not move the needle too much to and fro, because these are small 7 millimeter nodes and you can fall out very easily. You can see the capsule of the node moving as you go very gentle to and fro from the node. These are millimeter movements, and aspirated material was cytological examination. Following this, we are going after with the same needle. You can see calcification in the head of the pancreas. We are evaluating the vascularity of the lesion, and we do not want to traverse any obvious large vessels, so color Doppler signal is mandatory. Our technique for EUS-FNA is always try and go just below the biliary stricture. You can see the stricture of the bile duct, massively dilated CVD above. That's where we'll get probably the representative tissue causing malignant biliary obstruction. So here we have put the needle, gentle aspiration, not too much of to and fro movement, because we don't want to create a lot of bleeding. And then the material was sent for cytological examination. One pass is enough for it was an adequate material. Now, whenever we have very large tumor in the pancreas, there is a chance that you may have deformity of the duodenum leading to a difficult cannulation or selective cannulation of the bile duct. And this is exactly what we were trying to do. It kept on going probably in the partly into the pancreatic duct, and it was not very easy. So in view of this, what we did was we managed to cut the sphincter, the pancreatic ductal sphincter, We know that there is a large mass. We are not damaging the pancreas because there is an obstructive lesion anyway, and we cut through rather than doing a needle knife. We did pre-cut with a wire-guided sphincterotome, and then we went de novo above the cut, hopefully that we have cut the septum of the pancreatic ductal sphincter, and then we gently maneuver our way into the bile duct with a hydrophilic guide wire. As you can see, we have jumped across the tumor into the dilated system. So please avoid injecting contrast at any stage in ERCP unless and until you have reached deep into the intrahepatic biliary system, and there you start injecting contrast so we are sure of which ductal system you are going to drain. So here you can see on cholangiogram, a limited cholangiogram, you push the scope to see the stricture site, which you saw on EUS cholangiogram as well. So now we have already done EUS FNA. We will now complete the sphincterotomy. This is a partial sphincterotomy. You can see dark bile draining. So I'll extend the biliary sphincterotomy to push a stent. You can see dark infected bile being drained, and after the biliary sphincterotomy, we will go ahead and do the brushing. So here we are putting intraductal brush. Is part of our study protocol that even with EUS FNA from the node and the primary lesion, we'll go ahead and do some brush and get some material. And following this, this patient was requested not to place a metal stent. We feel that if there is a metastatic disease in the celiac axis region in the form of a small node, these are the patients who will benefit with a short stent, maybe a 6 centimeter uncovered self-expandable stent, and then assess resectability, and then take this patient for resection if need be, or just leave the patient alone if it's not resectable. Metal stent is anyway in the place. So here we are putting a plastic 10 French a Teflon stent, and you see gush of dark infected bile, free flow. As you can see here, a tremendous intraductal pressure leads to free flow of dark infected bile, and this completes the EUS-ERCP interface procedure for this patient. Free flow of bile seen and optimal stent deployment seen on fluoroscopy.